My name is Raina Ripple, and I'm the director of the Southwest Pennsylvania Environmental Health Project. We're a public health project. We're focused on serving the community and responding to the needs of people who are, we feel, being impacted by gas drilling activities. And currently, primarily we work in southwestern Pennsylvania, and more specifically we work mostly in Washington County, Pennsylvania, south of Pittsburgh. And we've been here for just over a year. We've been doing this for about a year and a half now. Officially opened our doors more likely in February of this year. And the reasoning behind that, we started this project, we started talking about this project in January of 2011, but before we really opened our doors to the community, we wanted to have a healthcare professional on staff. And so that was at the time when we actually found our nurse practitioner and started to be available to community members.
And why was there a need for an independent clinic of this sort?
We started, I'll rewind to how this really got off the ground. And so in January of 2011, I was working at my previous position where I was looking into coal mining issues. And in the course of my previous job, I was doing a fairly informal survey of just trying to hear from community members how gas drilling activities seemed to be impacting them, because of course this was pretty new to the area. And my previous organization, the Center for Coalfield Justice, primarily worked on coal mining issues. So we weren't at that time looking into the gas drilling activities. And I came from a public health background because I worked for Physicians for Social Responsibility for many years. So I had that interest, and I brought that to the table when I was going out into the community and listening to residents' concerns. And more I was hearing that the health issue was arising, but I didn't feel like anybody was really addressing it. And there was some possibility that we might be working with some of the academic institutions in the area, but for various reasons, we decided to go out independently and try and be entirely focused on public health, basically, and not be doing things so much in the research context, but be doing them from the perspective of public health, because we felt like there obviously were some concerns that people within the community had. And if we focused on this from a research perspective, that those concerns were not going to be addressed immediately. And that was our perspective. Our perspective was that there were some immediate concerns. People needed a public health response. There didn't seem to be an obvious state-level response that was happening. And so we decided to fill in the gaps.
And how do you make yourself known to the community?
Well, we started out by word of mouth because we really wanted to go to people who we knew were impacted. And so it's not meant to be, first of all, of course, a research project. So we're not looking for people who, are like a control group or anything like that. We're looking for people who think they do have health concerns associated with gas drilling activities. And we wanted to start off slowly because we didn't want to, first of all, we didn't want to get overwhelmed, and we wanted to have tangible resources available for people. So we wanted to go through the process of basically doing, it's like an environmental health history, but we do this intake process, and as part of that process, then we can start to figure out what the community needs from us. And so, for instance, is it an air problem that they're primarily faced with, or is it a water problem that they're primarily faced with? And the truth of the matter is it's both at this point in time, we see. So we have been engaged in really our first year of activity in trying to figure those things out, and then trying to figure out what kind of resources we can make available to people simultaneously. So we're not just going through the health histories and trying to provide even necessarily a medical response, because we see ourselves more as a resource center. So we take the environmental health history, and that helps us figure out how we can best craft the public health type of materials that people need. Do they need monitoring? Do they need, filtration devices? Is there some way we can link them into those kind of resources? can we work with some of the academic institutions and maybe make some of that technology available to people? Are there people who are doing the research into the water pathways of exposure, and we can, connect those people up? What are the, for instance, what are the medical resources for people? What are the clinical resources for people? So, I mean, we function in that centralized kind of again, more of a resource center type role. And we're filling in some pretty big shoes. We're trying to do something which traditionally you probably would expect a state-level healthcare, public health department to do. And in the absence of that, we're doing our best to make that happen. And because we don't have ties to any of the academic institutions, we're independent. We don't also have, any sort of political motivations. So we're so independent that we can move really quickly. We don't have any red tape to cut through. We don't have anybody that we necessarily have to answer to in terms of what we're doing, apart from the community. And that's who we answer to. Those are our clients. That's where we get our guidance from. So that's the scope of what we're doing.
And I want to ask you a little more particularly about the challenges that you've seen trying to direct people to health resources beyond yourself. But before
Absolutely.
we go there, can you just give us a sense of what you're seeing in terms of health effects and exposures? What is it seeing people are being exposed to?
Yes. When we started this project early on, we felt that we were going to see a lot of concerns related to water, and we were hearing a lot of concerns related to water. And so very specifically, some of the concerns we heard about early on were related to impoundments. Because what you have, of course, with gas drilling activities is you have what's called flowback water, and so the flowback water coming back up is going to be stored in these impoundments. And it's almost inevitable that there's going to be some level of leakage or spills associated with some of the flowback water. And so, there's a lot of chemical contaminants in there, and those may or may not actually be introduced by the industry, because when you have flowback water, of course, you understand that it's coming from the formation itself. So you actually have radioactive materials, naturally occurring radioactive materials, mixing with bacteria, mixing with biocides, mixing with all these toxic chemicals that are being put down, mixing with the salts, with everything, and it's coming back, and you again have these storage ponds, these impoundments, huge. And, so our concerns, the concerns that we were hearing from the community early on had to do with, well, is there groundwater contamination coming off of these impoundments? There's leaks, there's spills, there's runoff, there's all these things, and what's that doing? And, in some cases, they were actually even aerating these impoundment ponds. So they were actually, aerosolizing this toxic stew into people's air. So that was where air came in initially. And then as we've gotten further into this, we're starting to hear more about air. So, you understand, of course, that you've got the impoundments, you've got the diesel emissions, and there's a tremendous amount of truck traffic associated with this, and a tremendous amount of diesel emissions associated with the industry as a whole. So you've got compressor stations, you've got all the different generators, everything that goes on site, and then just the truck trips, like 500 truck trips per well. So that's a tremendous diesel exposure right there. So that was one of the air pieces that we heard about early on. Then you've got dust from the roads, all of that stuff. But then also what you have is compressor stations. So we're increasingly hearing that compressor stations, these are long-term infrastructure. They're not anything that comes up and goes away within the space of 3 to 4 whatever weeks. They're there to stay. They're there for, however many years, 20 years, 50 years, we don't know. But condensate tanks and compressor stations are sources of air emissions. And, whether accidental or intentional, these type of facilities are things that are definitely having an impact on air quality. And these are things that are sited relatively close to people's homes. And again, it's a longer term exposure of the chemicals or the toxics that are coming off of the air emissions. So air has risen in terms of importance and concern. So we're trying to address both water and air at this point in time, amongst everything else. But yeah, those are the two primary things right now.
And because of like addressing those things, what are like some of the symptoms that those things cause?
Okay, so one thing I think that is important for people to understand, and we take this into account, is that we didn't have the best air quality to begin with. So you had a population which potentially had some underlying health concerns, COPD, you had a lot of people who maybe worked in the coal mining industry, and just generalized air quality concerns related to coal-fired power plants, all of that stuff, the steel mills, everything. So that's you have to take that into account. You have to understand that our baseline water conditions may not have been great to begin with, but that doesn't necessarily mean that this population should have had additional impacts added to them. So respiratory is definitely one that we hear a lot. So people have a lot of respiratory concerns. We do hear of nosebleeds, and we hear of also gastrointestinal problems, nausea, vomiting, and corollary to that is kind of neurological, like dizziness, fainting, concerns about that. And then, and headaches, dizziness. I have a list of symptoms here. But you have to take into account the different populations. So you have a couple different populations. You've got the general community, of course, the people who are closest to these facilities. They may be exposed to the truck traffic. Stress is, I think, a big one, and I think that that's something that hasn't necessarily gotten as much attention and play because in some cases, you've got 24/7 light and air pollution. So that's kind of a no-brainer. So there's stress, but then you've got the worker population. So you've got the resident population, and you've got the worker population. And one of the things that I think is missing from the list of symptoms that we see is probably the impacts that workers are experiencing, because you'd have to understand that for the most part, workers are not coming to us. So we're not necessarily capturing all that much in terms of symptoms that the people most impacted, who are the workers who are, sometimes on these sites 24/7, are experiencing, toxic exposures. But I think as part of that, you've also got the skin. So a lot of people talk about skin complaints, but I think the worker population would probably have even more skin-related concerns associated with their immediate exposures.
Do you have evidence of things like increased asthma incidents after a well goes in, or where people can describe change in their health status that they at least self-report is connected to the drilling?
Asthma has not actually shown up to the extent that we would have thought, and so I don't know why that may be. But that's sort of from a more global perspective, and people aren't necessarily coming to us for whatever reason. I mean, we haven't gotten a large school-age population. We're starting to tease apart those kind of numbers and figure out, we've actually done a community health assessment. We're still in the process of doing that for Washington County. So that's going to give us the baseline data, because you have to understand, too, that this is relatively early on in terms of the industry impact. So, it's only been since really 2007 and, even like 2008, 2009 that industry activities have been happening very rapidly. And so, we have a snapshot of about 5 years' time in which to see some of these things happen. And it's surprising to see that asthma rates, for the most part, haven't actually risen if you look at it from a global perspective, by global, I mean Washington County.
Right. Well, how are they reporting respiratory?
Well, the respiratory symptoms, like we are talking shortness of breath, and
acute or chronic?
That's a really specific question that I think I'd have to check back in with a nurse practitioner. But I mean, and again, I'm going to come back to the comment I made early on, which is that this population already, some of our people that we've seen had COPD. So, it would be hard to necessarily tease apart exactly what may be associated with the gas drilling activities. But we do generally feel like people are saying, and I've certainly heard people say out in the community, I was okay, and the gas drilling started in February of 2012, And I've had problems ever since, whether it's dust, whether it's, the sand that they're using, it's a combination probably of diesel emissions. But a lot of people do notice that timestamp. So their symptoms, they feel like, are associated with the start of the gas drilling activities really ramping up. In terms of the really specifics of exactly what, the respiratory, like I can't necessarily break down the respiratory symptoms as clearly as like a healthcare professional could.
Do you encourage health journaling?
We do, right. And we're really trying to encourage certain things, and, it's hard because it's almost like the burden, well, it is, the burden of proof right now is on the population at large. So, in the absence really of like a state health department or of people, in a bigger picture doing the kind of work that we're doing, whether clinical or public health, we're a pretty small group and we're fairly constrained geographically. But it's hard to get, it's hard to expect the population who's already stressed, if you were stressed by this industry and you were struggling to maintain your life, your quality of life, and then you have to now do a health diary, you have to monitor these industrial activities, you have to track your health symptoms, you have to, do all this. So what we're trying to do, one of the things that we're really focused on, is trying to make it as easy for people as possible. So trying to either provide them some of the technologies that maybe could make it easier. Again, it is a burden. It's a burden for them to, first of all, experience these health impacts and experience the industrial presence, but then to also have to, do the job of theoretically someone else.
Can you give us a couple of examples of the pathways people take from how they found you? Did they see an ad in a community newspaper? Was it posted on the laundromat door? They come to you, you do the health history. My understanding is then you try and help them navigate into the health system. And one of the things we'd like to learn is, I'm sure you've learned a lot about the very specific inadequacies of the health system in trying to get people resources. So from kind of finding you through your work with them.
That's actually part of the reason why we haven't maybe taken this as generally public as I would like to have seen, because when I envisioned this project from day one, I said, let's do it, let's connect these people, and we're going to somehow find this magical network of healthcare providers who understand this issue and can treat these people. And that's not there. Yeah. So if I wanted to go and blanket the local laundromats with word of our resource center, and we all of a sudden had 30 people a day coming to us and saying, help, I would have to say, we can't really help you yet in terms of a targeted medical response to this. Because what we found pretty quickly is that the healthcare community needs education on this, and they need to be brought up to speed to understand exactly what this means for people. And you add to that mix the uncertainty that Act 13 brought to the table. So you had a medical community which probably didn't fully understand these type of toxic exposures. Yeah. And now with Act 13, there's a lot of uncertainty associated with that. So can they? Okay, so let me explain Act 13. And very specifically, there's a portion of Act 13 which my take on it is that it created uncertainty. So nobody really understands what it does or doesn't mean for healthcare professionals. But the idea was that healthcare professionals who were treating patients, if they felt that it was related to gas drilling activities and they might be looking at an exposure that was possibly linked to a proprietary chemical, that they actually had to get permission to look into that or to get information on that chemical from the industry, and then they couldn't disclose, not necessarily to the patient, but they couldn't disclose to other healthcare professionals what these chemicals might be doing or what chemicals possibly were being involved. all I can tell you is that it raises a host of questions that, I cannot tell you right now, oh, Act 13 means X, Y, and Z. And the fact of the matter is, for healthcare professionals, that I don't have that answer and that I don't feel the state has that answer means that healthcare professionals are functioning in an atmosphere of uncertainty, and they don't know whether or not they might actually get sued in terms of providing healthcare. So if I was a doctor and I wanted to treat a patient, I would say, this patient is suffering from nosebleeds, and I don't understand what the gas drilling industry may or may not do if I try and link this to that. So I'm going to treat the nosebleeds, and I'm going to try and make this patient better, because that's my job. My job as a healthcare provider is to treat this patient. I'm not necessarily looking at it from the global perspective. I'm not necessarily trying to treat a population. I'm not a public health person. And I don't know what Act 13 means, so better not touch it. Better just deal with what is going on right here and now and let somebody else worry about whether or not it's related to gas drilling.
When did Act 13, when did it become in circulation as something public health or medical people would think about in dealing with the patient?
So our understanding of Act 13, again, it basically came into play, this piece of legislation in the Pennsylvania State Legislature, or from the Pennsylvania State Legislature in February of 2012. So we've been trying to understand what that means, because the fact of the matter is it's still being challenged. So it hasn't been fully enacted. It's out there. The healthcare community is functioning with that level of uncertainty associated with it, but they don't really understand what it may or may not mean for them. And nobody does, because, again, it's being challenged. So it sort of hangs over the medical community as a potential threat. So as I had mentioned early on, we realized that water was a concern. And one of the things that we jumped on was, how could residents have a low-cost monitoring system in their houses? How could we make that available to people, and so that they could track things on actually more of like a daily basis, not a monthly basis, not 3 to 6 months, not like pre-drilling and then 6 months after drilling has happened, you do a snapshot of your water, but more like water quality on a daily basis. Because I think how we understand this issue is that you're experiencing your water quality issues on a daily basis. I mean, and is it safe or is it not safe for you to drink your water? So, for instance, we have this thing called the TDS meter, something that's relatively inexpensive. It's something that can provide people with just sort of a really basic tracking system, which could alert them to the fact that there's potential contamination. And this is a little bit, well, this is definitely more for well water than for city water, because your city water, you have to understand, is going through a water treatment facility. And so it's not necessarily going to show you spikes in treated city water. But if you had a well and this TDS meter showed you a huge spike in TDS is total dissolved solids, and they went through the roof, you'd say, oh gosh, I don't know what this is. This isn't going to tell you anything about the chemicals or anything about that, but it's going to alert you. It's basically like an early warning system, and it's going to tell you, I don't know what's going on with my water, but I should probably stop drinking it right now, or cooking with it, or if you can, showering with it. And so we wanted to put this in the hands of people as one option. And again, it's just an early warning system. What we would recommend then is, of course, that if that happened, that you would then take a sample and you would get more extensive tests. But it would tell you right then and there, my water may not be safe to drink. And so from a health perspective, it basically puts that tool in the hands of people and arms them with the knowledge they need to make that decision, about whether their water is safe for them to use. So that was one technological option. This is about as low cost and simple as it gets. And we are looking similarly at some of the air type devices that people could use. But we've been working with, we've started a working relationship with, we haven't finalized it yet, but we're trying to work with what's called the Create Lab out of Carnegie Mellon University. And they've been coming up with a lot of devices for both air monitoring and water monitoring. There's two devices in particular that I'd reference. It's called the AirBot, and then they've got this device called the Catfish. So the Catfish, which we think is really cool, is a toilet tank monitoring device. So instead of this is sort of similar to the question you asked about health diarrhea. So instead of asking a person to monitor their water with a TDS device every single day, the catfish goes into their toilet tank. It's a continuous source of water that's being refreshed, and it can tell them in a readout, very simple and easy for them to use, what's happening with their TDS, with their pH, with all of that. So it takes that sort of burden off of them a little bit. It eases the burden at least, and it's a cool piece of technology, which we thought people would probably be excited about. So we're trying to work, again, with the Carnegie Mellon University, the Create Lab, to get this technology put out there in the community. And I'm continuously getting feedback from people about what may or may not be helpful. And I have heard that that is a device that I think would be helpful, because I've talked to some people who are really active on this issue. They're working with their community, they're trying to deal with this, and they have the TDS monitor, and honestly I can't be bothered to do it on a regular basis because I'm pulled in so many different directions. I'm busy, I'm this, I'm that, So our feeling is that at least in some cases is going to be a really useful device for people to have.
Are you taking back data from people or
Yes.
encouraging them to give it to someone else? So how are you curating this data?
And that's related, again, more to our air monitoring approach, because this is one of the things we started doing with the water. And so we encourage people to do their TDS readings, and we actually have at least one person who hasn't had drilling activities yet and who is continuously providing us with his baseline monitoring. And that, I think, is a very useful thing, because that person is in the path of gas industry. So we want them to capture that data as much as possible. And so from the air perspective, what we've also done with the community is we've used this device, we've made this device available to people as much as we can, called a Dylos monitor. And what a Dylos monitor does is it captures particulate matter, so and what's shorthand known as PM. So the particulate matter could be related to diesel emissions. That's an easy, obvious answer. It generally is those type of emissions. But particulate matter is an important indicator, similar to TDS, because it can be a carrier, but it's also something that's going to spike, if there's a lot of industrial activity in your area. So you can use the Dylos monitor to get a continuous monitoring picture of what is happening near your home. So what we've done is we've taken this Dylos monitor out, we've made it available to people, and there's been a lot of interest in this. And we've gone through a pretty labor-intensive process, because of the technology that's available to us right now, of actually charting out air emissions, particulate matter emissions, from these Dylos monitors in people's homes that are close to gas drilling activities, whether it's a compressor station, whether it's a well pad, or whether it's a lot of times a combination of those. And then what we do here in the office is we actually provide them with a really detailed report of what happened in their household from this Dylos monitor compared to what the ambient air emissions look like in Washington County, Pennsylvania. So we provide this report back to these residents, and it is helping inform us on what is safe and what kind of exposures people might be dealing with related to compressor stations, related to, again, well pads. So everything that we do, we use it as a tool both for them and to educate ourselves, so that we can take one more step forward in terms of crafting a more generalized public health response for the community at large. So we stay pretty busy.
Are you seeing acute spikes in PM?
We are seeing acute spikes in particulate matter, yes. And these levels are, if you look at background levels, okay, so a particulate matter background level might be, say, 500 to possibly even 2,000, and that's PM, I think that's PM 2.5, but anyway, those numbers probably don't matter. So particulate matter in general, background levels would be in the range of like 500 to 2,000 as just a general measurement. And the spikes we've seen in people's homes have been in the range of 7,000 to possibly even like 8,000 or 9,000 in some cases. So, you would expect to see a spike of maybe 2, possibly 3,000, and then when you get up into 7, 8, 9. I mean, that's very unhealthy by EPA standards. So that's the kind of level at which everybody should basically curtail all their activity and stay inside in a filtered environment. You wouldn't want to engage in any sort of activity, no matter how healthy you were.
But these are indoor levels. Where are you taking?
Right. These readings are coming from inside people's homes. So, there's been some debate about, well, do you do the measurements on site? Would you want to go to, say, what's called a fence line and do a measurement that's closer to the source of contamination? But, we're concerned about where it's impacting people in their homes. And yes, those are the kind of readings that people are seeing in their homes.
And are you able, and I know you can't causally connect it, but does it look as though it's a trucking related spike? Is it related to any stage in the drilling process?
It's a combination. I mean, and the answer to that is, again, too long. It's too detailed. And we're in the early stages of trying to tease that apart. But again, you're talking about an industrial activity that has a whole range of emissions that are coming from the diesel, that are coming from the truck fleet, the truck traffic. It's associated with all sorts of stages. I mean, you've got well pads, you've got flaring, you've got compressor stations. And the problem, too, in answering your question, is that you don't just have one of these things in any one location. So a person who may be sitting in an area, and this is common in Pennsylvania, that somebody may be sitting in a valley. So they may be below these facilities. So they might have 7 well pads around them. And, which well pad caused this? And, or was it the compressor station, or was it a combination? The chances are pretty likely that it's a combination of all these factors. And it's beyond our scope, certainly, and our ability to tease those apart. But that actually gets to part of the problem, because from a regulatory perspective, and we take issue with this, they treat each of those facilities separately. So there's no aggregate of the impacts. And let me tell you that these facilities all sneak in under what's called a major versus a minor source of pollutants. So if you're a minor source of pollutant, you don't have to use stringent emission controls like you would if you were a major source. And so if you had a person living here and they've got 7 minor sources of pollution ringing their home, and nobody from a regulatory standpoint is aggregating, putting all those sources together, because they are a major source and they should be being regulated as a major source of emissions, but they're not. They're being all regulated as minor sources. And that's not working in terms of protecting these people's health. So that's a really big concern we have.
So do you think that you could go as so far to say as like, what is this, like if they're all being categorized as minor sources, what is the step, what is the call? Like, is there the call that you don't have these wells within a certain distance of people's homes, or like what's the next step you could take that to?
Well, if those were considered as an aggregate source, then yes, what would happen is then they would have strict emission controls, or they would have much stricter emission controls. So they wouldn't be allowed to emit in the way that they're emitting right now, which we do feel from a cumulative perspective is clearly a source of human health issues. And it's impacting our air quality from a regional perspective as well as a very localized perspective, these people. So the answer is complicated by politics and policies and, all of that, but the truth of the matter is that from a regulatory standpoint, from a human health perspective, at the very least, these sources should be considered from an aggregate perspective. And that would make a difference in terms of what was allowed.
What kind of documentation are you taking on the health side? And I know you've got HIPAA restrictions. And what are you, and things like, are you doing self-reported proximity? Are you taking address and geocoding? And then what is your plan for what you do with that documentation as a organization?
Right. That's still in the early stages of being worked out. But the answer to your questions is yes, we're doing all that documentation. What we're doing essentially is we basically take an environmental health history. So we take into account whatever other factors may be already present in our patient's background, and then how that's associated with gas drilling activities. And we very specifically ask the question, how close are you, and what are these type of industrial facilities which are near you? How much truck traffic are you experiencing? When did it start? And we need to do more in terms of defining when their health symptoms started in correlation to when these industrial activities may or may not take place, because a lot of that stuff changes on a regular basis. So the well pads go up and down. The compressor stations are more long term. And I haven't even talked about pipelines, but so we're doing that in terms of making the data available. Like what we're trying to do, and I'll just show you a couple different examples. And this may not show up, but this is an example of kind of us taking an aggregate, a cumulative look at some of the intake forms that we've done and pulling out some of the symptoms that are most prevalent, and then we're doing this for our own project specifically. So we're taking this data from the health intakes that we have completed. And we're also working with other physicians and trying to pull that out of whatever other activities have been done to capture symptoms from other physicians or healthcare providers or other surveys. And so we're working right now, with like 50 to 100 basically cases. And one of the things that we're ultimately going to try and do is turn that into a case study. So detailing out what we've seen and doing some type of publication that would make this more readily available to the healthcare community. And alongside that, of course, I hadn't really talked about it, but we're trying to educate the healthcare community on what we're seeing and what an appropriate response to these type of symptoms would be.
That's a good lead to another question is, how are you connected to the local healthcare community? I mean, do you ask people to put themselves on a list? How do you, and I know that's a laborious and long-term process, but what's your kind of local ecology?
We started out early on with, we've done surveys of all the healthcare professionals we could find to talk to about this issue, and early on we realized that there wasn't enough awareness and or interest or even willingness to step out on this, because a lot of healthcare professionals are taking a very cautious approach to this right now for various reasons. But we decided that we were going to start the process of educating the healthcare community. And so we did that. We actually had an event here in Washington County on July 20th of this year, and we drew in people from the Pittsburgh area. We drew in people from West Virginia. Actually, quite a few people came up from West Virginia to attend this with us. And of course, in and around Washington County and southwestern Pennsylvania, or western Pennsylvania, really. So we did that as a pilot project or a pilot event because we wanted to see how that went. And as part of that, we developed what we call a medical toolkit for physicians, and we made that available online. And the feedback we've gotten so far has been, this is pretty much all that's out there in terms of educating the healthcare community right now. And we're trying to take it to the next level. So we're trying to expand upon that, make that available to more people. There's a couple groups I'll mention briefly that we were working with on that. Physicians, Scientists, and Engineers for Clean Energy, PSE. They're actually going to, they did come, they did an interview with our toxicologist and with our nurse practitioner, and those materials are going to be made online, available for healthcare professionals to educate themselves on the toxicology associated with this issue. And then I'm also working with Physicians for Social Responsibility to try and figure out how we can do more healthcare provider training. So nurses, doctors, everyone that we can educate on this. We're trying to take this on the road and take it out. And I know that the Maryland chapter of Physicians for Social Responsibility has borrowed heavily from our July 20th training to work on a similar thing, which I think is happening in December. So that's always been our focus too, is that we see ourselves as a pilot project, and we want people to take it and run with it, so that we want our materials to be made available and our model to be made available to other locations so that they can replicate what we're doing as far and wide as possible.
Are there health advocacy organizations elsewhere that have experience with this that you can model on? And for example, I know something about the work in Colorado.
Yes.
I don't know if they've done anything into the health community, but
We have done an exhaustive review of all the literature, and we've talked to almost every person that we could find out there who's either researched this issue or who has directly been working on this issue. We've talked to people in Texas, Colorado, Wyoming. We've taken all that data to craft what we're doing. So there isn't any other resource center like us out there. So we're modeling something totally new, basically, and you know, we're trying again to figure out how to pave the way for more of those type of activities to happen. And you know, I've developed relationships with a lot of the people in the Philadelphia area who are working on this, so we could take it more statewide at some point. I'll mention this one woman who we work really closely with, Dr. Pune Saberi, is out of Philadelphia, and she's been doing an immense amount of work right from the beginning on this. So she's probably our closest partners, definitely from Eastern Pennsylvania, on this. And of course, we've talked to Roxanne Witter, who's out in Colorado. We've had multiple conversations with groups down in Texas, and again, we've looked at everything. We've taken into account all the literature that's out there, all the research. We've had those conversations, but no, there's no other group quite like ours.
can you just say a little about I guess it's your board, the list of people on your website that are your consultants and things? And
Right.
one of the reasons I ask is who's helping decide? I mean, there's a zillion things you could do. So who's helping direct your effort? Is that a collective board process? Why are those particular people on your board?
Well, and specifically, we function as a project, and we have a host organization, the Foundation for Pennsylvania Watersheds. And the reasoning behind that is because there was such an urgent, immediate need for us to get up and running, we didn't really feel we had the time to necessarily create a whole 501c3 structure or a board. So what we have is we have a team of consultants, and we're all working on a regular basis to figure out where we're going. But the primary guidance for this project comes from a couple of us, and more specifically, there's two people who shape this in addition to everybody else that we work with. I mean, we've got an unofficial advisory group, including a lot of people that we work with out of the Yale School of Occupational Medicine. So we work with them, we work with West Virginia University, but the primary guidance comes, again, from our toxicologist, Dave Brown, who has years of expertise on working on Superfund sites. So he's shaped this as much as anybody. And again, he comes at it from the toxicology, public health perspective. So he knows how to do this, to craft an immediate response, even in the face of, you know, there's a lot of uncertainty. I mean, there's almost, in some ways, nothing but uncertainty right now, or there's just so many questions. But we know that answers exist because we know that, you know, certain chemicals are proven to act in certain ways. Diesel is an obvious problem, and so that's well understood. I mean, that's not a mystery, you know. So we can pretty much tease apart those certain concern or chemicals of concern, toxic exposures of concern, and then you could look at noise pollution, light pollution, you know, stress. What does that do? I mean, those are all well understood to have certain health impacts. And so from his perspective, again, this is Dave Brown, the toxicologist, he helps guide us. And then we also work with Norm Anderson, who's an air quality specialist, who actually was somebody that I had a prior working relationship with. So he understands the big picture in terms of the air. Dave Brown, again, the toxicology, as well as the air. And then we've had really great working relationships with our foundation support and primarily the Heinz Endowments, and they work really closely with us as well.
Why are they committed to these issues?
Well, the Heinz Endowment sees this. I mean, they are coming at this too from serving the southwestern or western Pennsylvania community, and so and they also have been very much in a leadership role in terms of the air quality issues in southwestern Pennsylvania and in western Pennsylvania. So because the Heinz Endowment has such a commitment to air and water and all of these other issues and the environmental concerns associated with this, they are really a great resource for us to work with, and that's part of the reason why they have that commitment. But they also have a commitment to the health, and I think they see us as certainly one of the best places to really address health and public health in terms of how this is playing out.
Right.
Can I, are you?
I have one more question, and this is pretty pointed. Dr. Corbin, does he work with you?
Cian Porbin, yes, Dr.
Okay.
Cian Porbin.
He's quoted in an NPR article from last spring sometime, saying that it sounds like he's involved because he wants to see if anything's going on, and
Right.
he said at that point he wasn't yet persuaded that.
Right.
And so, have you actively brought in people? Who is he and what does he represent for your board? I mean,
Okay. Dr. Cian Porbin, he has a practice out in Avella, Pennsylvania, which is the heart of some of the most intense drilling activity in Washington County. And he serves the community out there. He had, as you mentioned, said, he doesn't necessarily see a large part of his patient population being impacted by this. And that, I think, is an important role for us to understand that, again, he's on the ground. And if anybody's going to understand this issue, it's going to be him. He's actually somebody who had a previous working relationship with our nurse practitioner. What he does for us is he is actually what's known as our collaborating physician. So as a nurse practitioner, you have to have a working relationship with a physician and in order to have prescriptive authority. So he functions as our collaborating physician, and he's somebody who, it's almost like we see him as a good indicator of the healthcare community's understanding of this issue. And so if we can educate him on the kind of concerns that we're seeing and what we're hearing from the community, and he comes to a fuller understanding of what may or may not be happening, then we can use that as a barometer, basically, of how well we've facilitated that interaction with the medical community at large.
right. Now, and I realize just how quickly both the gas development is developing, but also people's understanding of what's going on. Do you think, and not him in particular, but someone that last May would say, I'm not yet seeing any patterns, do you think that would shift even 6 months later?
I think in some ways, yes, and in some ways that, unfortunately, a lot of the things are going to start to become more apparent possibly even 10 years down the line. And the reason I can give for that is that you look at Texas, where drilling has been going on for 10 years, and from a health symptoms perspective, you're going to start getting more of the chronic diseases. So we definitely have concerns about more, again, chronic illnesses such as possibly leukemia and things like that, and cancers. But those aren't necessarily going to appear right away. So, it's hard as a healthcare professional because they also function within that need for certainty. So they want a very high level of certainty before they're going to say yay or nay on something. Public health can function differently than that. And that's where we play that kind of bridging role in terms of saying, from a public health perspective, we know these people are being impacted. I mean, you can look at it from a variety of different ways. You can look at it from noise, light, stress, and then the toxic chemical contamination. But those things are going to be more long-term. And, in the absence of research right now, in the absence of really understanding what the industry is or is not doing to these people, it's not hard as a medical professional to be uncertain. I mean, if I was a medical professional and I wanted 95% assurance before I said you do or you do not have cancer, I mean, that's where they come from. And so, again, we bridge that gap between what the public health community can do and leading the medical community to a better understanding of this.
I have a question. You're talking about looking at like Colorado and looking at Texas, and like you're here as a very new organization on the ground doing what you're doing in terms of public health. But we're coming from New York State where we haven't even started putting anything in the ground. Like kind of like if you could like pie in the sky vision, say fracking is definitely going to be taking place in New York State. Say that is like this fantasy.
Okay.
Like what is your advice? Like no, like don't put
Don't do
wells.
what?
Like don't do what? Like what are the mistakes that have been made?
Okay, well, I know exactly what I would recommend. And that's a good feeling in some ways, but it's a bad feeling because it's not what Pennsylvania has done. The New Brunswick Department of Health has recently released a report. And in that report, they have basically forecast what an appropriate public health response to gas drilling activities would be. And I would follow that from day one, before any of this started. If I was looking at this from the New York perspective, because you are in that fortunate circumstance of not having it yet taking place, that's what I would recommend, is those guidelines that came out of the New Brunswick Health Department. And again, that was a public health model for how to go about this before anything happens, before any of it starts. And if Pennsylvania could rewind and do that, I would say we should have done that, and we are absolutely not doing that. In fact, for the most part, we're doing the opposite of what they recommend. And so that's part of the reason why I think we're in the shape we're in. They looked at it from a really broad perspective, and they looked at it from how it was going to impact communities from, the pretty basic, medical, toxicological impacts, as well as this sort of sociological boom and bust scenario. Because what you have is an industry which comes in and explodes into an area, and a certain percentage of the people are going to be impacted really financially positively and make out like bandits, and then some people are going to suffer significantly. And the tensions that create, that was one of the good things from a public health perspective that this New Brunswick report tackled, which was not just the basic, contamination issues, but the larger social issues that are associated with a huge industrial development, and one that's very localized, one that's not happening, and one that's decentralized. So you don't have your kind of traditional industrial model of, say, one polluting facility that's located, and is impacting one community nearby and the adjacent people most directly, but you have it scattered and dispersed widely. And so what does that mean for the population at large? And so I'd say that's probably one of the best things that came out of the New Brunswick study, is that it looked at it from that perspective. It looked at it from the broader perspective. It gave really clear guidance on how that translates into the population's health. And, they found, and I think this is one of the most interesting studies, is they found that, the economic benefits overall, and definitely the health impacts, you would expect when you've got an economic situation where all of a sudden, a lot of people are much more well off than they were, that would actually increase the overall health of the community. But they found no net positive result that they would expect to see in this scenario, because the negatives would outweigh the positives, or would balance them out to the point where it was a net negative. So even though it's a major economic driver, potentially, for an area, ultimately from a health perspective and from a public health perspective, it's not, they see it as necessarily a positive thing overall.
In part because of the distribution of benefits and risk and all of that. Why is your clinic here in particular within the county as a whole?
Right, and we are located in specifically McMurray, Pennsylvania, and Washington County, Pennsylvania. And the reason for that, there's a lot of reasons for that. More specifically, this project to some extent was built around myself as a unique person who had community connections. And I came from working in the community on coal mining issues. And in addition to that, we have Pittsburgh. We have two facilities, really, or two areas that we can call upon for assistance from an academic community, and that's Pittsburgh, of course, and then also the colleges and the facilities down in West Virginia. So we're placed between those two centers of both, medical resources. There's the University of Pittsburgh Medical Center. There's the University of Pittsburgh. There's multiple public health entities, both in West Virginia and up in Pittsburgh. And, there's a lot of academic institutions that we can call upon to assist with this. And you have a pretty robust set of NGOs, of people who are trying to work on this from a policy perspective. Again, you have a lot of resources relative to, say, Bradford County, because if you looked at Pennsylvania, you would say, well, Bradford County has suffered from probably more intense impacts, but unfortunately they don't have the same type of resources where a project like ours could start up as easily in Bradford County as it could here in Washington County. So we were well positioned to be in a place where drilling activity was ramping up, and this is probably the second most heavily impacted county. Washington County and southwestern Pennsylvania in general, and Bradford County are kind of the two centers of drilling activity right now. But again, you've also got an instance in Washington County that's a little bit different than Bradford County, because Bradford County is slightly more rural even than Washington County. So in terms of where the industrial development is going to be located in close proximity to a larger population, that's actually Washington County, somewhat more than Bradford County.
Is there a reason why it's in a prosperous township like this, rather, you mentioned, like where Dr. Porvin's clinic is,
Right.
You said is right in the heart of the beast. Why not put your offices there?
Yes, there is a very specific reason, which was we wanted to situate ourselves in a neutral setting. So we wanted people to feel comfortable coming to our facility and to not feel, because you're talking about a small town community. And if, say, a certain, car was well known in the community and they went to the Southwest Pennsylvania Environmental Health Clinic, guess what? Everybody in town would know that this person maybe was concerned about their health related to drilling activities. And, word gets out pretty quickly.
Yeah.
And so we deliberately removed ourselves from the center of activities and located ourselves in a relatively neutral space, which McMurray, Pennsylvania is a center of healthcare facilities in general. There's a lot of different rehab practices and, dental offices and primary care physicians here. So it's about as neutral a place as we could find that was also right within the close proximity to the heart of the drilling activity. So, the place where the drilling is the most active is maybe 15, 20 minutes away. So, again, distance, not a tremendous geographic distance. We're also close enough to West Virginia that people could make their way to us from West Virginia too, and from Ohio. So it was a very deliberate choice.
And at this point, it's word of mouth by which they're finding you?
Yes, primarily it's word of mouth, and we've networked within all the different networks that we could find to start off with, and the reasoning behind that, again, was that I wanted us to have the resources in place that we could really assist people when they came to our office. So I wanted those things before we really threw the doors too wide open. So I think now that we're moving into year 2, we're in so much better shape to actually do that and to really ramp up our outreach activities and our clinical services to people.